I'm now going to turn the podium over to my good friend and colleague, Dr. Ed Fox, who is the director of the MS Clinic for Central Texas in the Austin area. And just in terms of his background, Dr. Fox has MD, PhD through Baylor, and his PhD was in immunology, so he really is perfectly suited for an MS talk. He also did his neurology residency at Baylor and is currently a clinical assistant professor of neurology at the University of Texas Medical Branch. So please welcome Dr. Fox.
Good morning, everyone. And I would also like to thank the organizers and the sponsors for this meeting as well. It's very nice to be able to cover the broad depth of topics that we're going to be covering today regarding MS. And so as we start this, I'm going to be covering a couple of topics here, but the first one is the changing view of immunopathology and MS treatment. And this is, the operative term here is changing. Every year I could give this talk and it'll be a different talk, and I can guarantee that whenever making a discussion such as this, there will be several things that will be out of date over time. We will learn more, we will amend, we will change our, where we are in terms of this knowledge. My disclosures are present on this slide as well, and as I said, I want to thank France Foundation and the rest of the organizers. So my learning objective for this first talk is to integrate new information on the immunopathology of MS into the treatment decisions that we make regarding a patient on an individual basis. In order to be able to determine not only what might be the best choice of medications, but also how to follow a patient over time to determine whether in fact that decision. So covering the general topic of MS, one of the things that you always want to do is talk about the prevalence of the condition in the first place. Within the United States, we know of over 400,000 individuals that have been diagnosed with MS. We're trying to get better databases on this as possible to amend that number, because it is a general belief, at least, that the numbers have increased in recent years. There are over 2 million cases worldwide, and we do know that there's a higher prevalence in certain areas of the world than others, and I'll show you a map to that effect in a moment. The incidence of MS is greater in women than in men, and the disparity between men and women seems to be growing over time, which is a great field of interest in itself, because it may explain a lot about the underlying causes of MS. The typical age onset is during childbearing years, between 20 and 50 as onset, although you can see pediatric cases, and you certainly can see geriatric cases as well, so it would not be true to say that it must occur in this age range. The 2 to 5% that are seen in pediatric cases, there's been a lot of question as to whether it's the same disease or not. I think that presentation may be somewhat different, and the MRI findings can be somewhat different, but it is at heart still the same condition, a demyelinating autoimmune condition. The presentation of MS, there are a number of different presentations that can occur based on the symptoms being expressed, but 85% will have a relapsing form of MS at its onset, in that there will be a flare-up, as you had in the case study that we showed before, of a clinical event. This is the map that I had mentioned a few moments ago, showing the incidence of MS in different areas of the world, and by color-coded you can see that they're quite different. And even within a given country, there can be quite a gradient. There can be a gradient based on latitude. There could be even a gradient based on altitude, of how high over sea level you live. And so when you look at something like this, it doesn't really tell you everything you need to know about what the underlying cause is. Is it environmental or is it genetic? Well, worldwide, you're going to have different environments and genetic backgrounds for people living throughout the world. But what it does tell you is that it's not just a completely random disease. It doesn't occur in all people at an equal rate. I mentioned that 85% of people who are diagnosed with MS present with a relapsing form of MS, and this just shows the different criteria that we use for that. If you're looking at clinical disability going up on this scale, the one that is the best known is the relapsing remitting form, where there are individual events that will take place, and the individual events may occur rarely or may occur quite frequently. That's the variability you see between patients. But over time, classically, what you can see is a secondary progression, a worse form of the disease developed later on with increasing disability with or without the presence of relapses during that time. A primary progressive patient may have variable symptoms somewhat, but they're not known for having a new symptom that then resolves as a relapse and then a remission over time. The pathophysiology of MS, so, is it at heart a central nervous system disease or is it an immune disease? Well, it can be considered both because you certainly can see the pathology at the level of the central nervous system where you've lost the myelin on the surface of the CNS axons. You'll see areas of acute inflammation at times and chronic inflammation. You'll see scarring that takes place. That's what sclerosis is. So gliosis that occurs in various areas of the central nervous system. And you also see the atrophy, the loss of the axons that takes place that can seemingly be independent of inflammation. So even normal appearing white matter on an MRI is not truly normal under the microscope. So it's a more global process. It's not just patchy areas of inflammation. The major cause of neurologic disability, we do believe, is the loss of the axon, so a dying back. Certainly a demyelinated nerve that still has an intact axon will not conduct the electricity through normally, but it is at heart a loss of neural transmissions that's causing the symptoms that are so typical in MS. When we go on to talk about the immune system, the two parts to the immune system, there's the part you're born with and the part that develops later on. Innate immunity is a rapid response system. It doesn't really differentiate between one antigen and another. It isn't dependent on immune memory. So it just reacts to something that is present that could be declared foreign, basically, and need to be cleaned up. We have it throughout our tissues in the body. So certainly there are pockets of area where we know that there's a lot of immune activity, our spleen, our bone marrow, the thymus, and so on. But when we're talking about the innate immunity, we're really talking about essentially all tissues of the body. The adaptive immunity, so it's adapting to whatever environment has been presented to the individual, that's slower to respond. So if you catch a cold, it takes days before your immune response really kicks in. And you start making antibodies against that virus. Those antibodies are produced and the cells are upregulated, and then it runs its course. And then over a period of weeks to months, the number of those cells that react to that antigen can die back. And then there's a memory to that as well, because those cells that have been stimulated are still present. So we have the cellular mediated immunity, which is based on all the different cells of the immune system that react. Humoral immunity is generally, when it's mentioned, it's talking about antibodies, but the idea is that you have an immune surveillance that goes on throughout the body. So the innate immunity, neutrophils are the first responders. There's certainly, as phagocytic cells can eat bacteria and viruses, that's what they're known for. The monocytes are there as well, and they differentiate into activated macrophages. This whole line of work going on about these cells, because their involvement in MS is really indisputable. It's just a matter of determining for individual therapies what effect you're having on all these cell types. Natural killer cells are present as well. These are the killing machines of the immune system. And certainly infected cells or malignant cells, so on. I mean, these play an important role as well. And now we're realizing that there are therapeutic avenues that can be approached even for those cells with regards to MS. The adaptive immunity, though, historically has been what we really talked about a lot in MS, and that has to do with different subsets of T cells as well as B cells, the antibodies that are produced specific to antigens, and complement as well. So T cell activation, resting T cells, Th0 cells, go into activated T cells, mature ones, and they can be in different lineages. Th1, Th2, now Th17 cells are talked about as well. And this is not random. It has to do with the environment in which the cell is activated. What I'm going to mention about this is that the immune system in one area of the body can be reacting in one way, and another area of the body can be reacting in another way. And even within the central nervous system, when you have old lesions and new lesions, the cells aren't all behaving in the same manner. different cell types are there and different activities. The Th1 cells are the ones that we consider the more pro-inflammatory cells, and it's because of the cytokines, the chemicals that they produce and that they react to, as opposed to Th2, which are important as well, but in the models that we have for MS are not considered to be the primary inflammatory cells. Th17 cells, as I said, a newer concept, has been differentiated from the Th1s, and they react, again, differently on a chemical basis, and they're considered to be profoundly inflammatory as well. B-cell activation is not ignored in MS now. It certainly used to be. One of the many things I used to say that is no longer correct at all is that B-cells had little to no function in the pathology of MS. And we know that to be patently incorrect now, that the B-cells are quite involved. And so B-cells certainly can not only react to the environment, but they can also create an environment as well. And so the co-stimulatory molecules between the T cells and the B cells and the monocytes and so on are all very important. And so it's obviously a complicated interaction of all these different cells. The monocytes, macrophages, microglia, dendritic cells, this whole line of cells are ones that can be very much involved in the pathology of MS based on the amount of destruction that they can do to the myelin directly and to the axons, that they can lead to axonal death, dying back of the axons. And all of these cells are interacting with the others by production not just of the antigen that's presented on the surface, but the production of chemicals that will transmit across from their cell to another cell and thereby lead to an environment where those cells can be activated. So to review what I've said about immunology, it all boils down to saying, well, there are a lot of cells and it's very complicated. And I apologize that that's about as far as we can take it. But really what questions that we all would have are, well, what is interacting with the immune system that leads to this specific disease? Why is it that in one individual they might get rheumatoid arthritis and be attacking the synovia, but in other it would be psoriasis, the skin, but in the cases we're talking about today, it's MS. And what cells are involved, how are they involved, and what targets does it give us for therapeutic avenues? So this is when you put it together, the obligatory slide that is far, far too complicated. All immunologists are required by union rules, I think. But to do this, Dr. Cree is going to be showing this later on today and sort of delving into a little bit more of this. But I think the take-home message for this is that there are two compartments. There's the peripheral compartment that's happening out in the body, and then there's a central compartment because these cells have been able to go past the blood-brain barrier and get into the area of the neuron and cause axonal damage. And all of these cells might be involved. And it's not that one patient is going to have all of those cells involved. And it's not going to be that every patient has every cell involved. It may very well be that the explanation for why medicines sometimes work better for one patient than the other is because certain cell types are more pathologic in that individual than it is for others. I mentioned the environment really matters, and this is the other slide that Dr. Cree is going to be showing later on. And just to introduce it, when you're looking at differentiation of T cells, I mentioned the environment counts, and it's because there are different cytokines, these markers that you can look at in terms of being able to say that a chemical has been a cell has been activated, and so it is producing certain chemicals. So when you have a naive cell that has been activated, you can see that it can become pro-inflammatory, which I mentioned is Th1, versus more of an anti-inflammatory profile, which is in the Th2. And you can measure that by seeing what's now presented on the surface of those cells and also what chemicals or cytokines are being produced by those cells. You can break it down now into the Th17, as I said, another subset that looks like it's pro-inflammatory, as opposed to the regulatory T cells that are present in the immune system. And I think the regulatory cells are of great importance for us to understand, simply because what we want to do is to regulate the immune system in an MS patient. And so anything that we can do that would downregulate the pro-inflammatory state, whether it be by killing the cells or by just diminishing their activity, would be expected to have a positive influence on control of the disease. anything that would upregulate regulatory nature of the cells to be able to again inhibit that inflammation would also be considered to be a positive influence. So we're trying to regain a balance here that has been lost in MS, where we have too much of an inflammatory nature going on and not enough of the anti-inflammatory. So if you change the immune system, and that's what modulation is change. So if you use an immunomodulator, anything that you're going to use, whether it be to increase the anti-inflammatory or decrease the inflammatory, is meant to maintain an adequate immune surveillance for an individual so that they can fight off infections or tumors, but that they would not have an overly aggressive inflammatory nature causing the damage in MS. As I said, B cells are involved, and B cells are involved in a number of different ways because they interact with a lot of different cells. They can actually present antigen. They can activate T cells. They can activate the monocytes. And the numbers of ways that the B cells are involved is really still evolving. Within MS, at this point, I cannot look at an individual patient and say how much of a relationship the disease has to B cell activation. I can just presume at this time that it is present in all patients. And because of that, the therapeutics for MS are now also looking into means of treating the disease by treating the B cells specifically and directly. B cells develop over a period of time. They go from very naive cells to the antibody-producing cells. And this also leads to discussions of topics. Same way I had said that Th0 cells can go to Th1 or Th2, Th17, so on. Well, it's the same thing with B cells. So there are markers that are present on the surface of the cells only at certain stages of development. So in fact, you can target a certain type of B cell, not every single cell in that lineage. And I think that that's very important as we look forward therapeutically to say, all right, is there a way that we can maintain antibody production for activated cells and yet decrease the activation of earlier stages of the lineage so that you're not getting the activation within the central nervous system. And this leads us to a discussion about where MS starts. Is it more of a degenerative situation, or is it more of an inflammatory situation? And this goes to the inside out or outside in. If you're talking about outside in, you're saying, all right, cells get activated outside the brain and spinal cord, and then they go across the blood-brain barrier, and then they cause inflammation against the myelin within the brain and spinal cord. That's sort of the classic way we've thought of this disease, because under a microscope you can see these inflammatory infiltrates occurring in the brain in acute lesions. But there's also the inside out, which is that there's degeneration that is going on from the beginning in patients with MS. And by the release of a bunch of antigens from dying cells, the immune system secondarily gets activated. And so it is at heart a degenerative disease where at times you see acute inflammation as a response to that degeneration. This is controversial. This is not something that we fully understand. And once again, it may be different from one patient to the other. But if we look at the sites of demyelination, you can see early myelin destruction going on if you happen to have a biopsy or something and looking at this, or using the animal model. And sometimes what you see is a degeneration not starting from the outside of the myelin sheath that winds around, but actually dying back from the inside out. And that would be a specific, I think, indication that there could very well be a degenerative process of the myelin first before you get an inflammatory destruction. The outer myelin wrap can be intact at the same time the inner is being sloughed off. The autopsy of patients in early active MS, they sometimes show a lot of macrophages that have invaded one of these lesions, but they don't see that there is the typical infiltrate where you can see the cells on the surface of the myelin degrading it. Admittedly, however, how many times do we have autopsies of acutely presenting MS patients? This is extraordinarily rare, thank goodness. And because of that, this may not be representative of the disease as a whole. This may be representative of a certain type of fulminant degenerative, then inflammatory condition that could cause early death. But this type of this line of research does suggest that demyelination can precede the inflammatory infiltration. I'm not trying to make it sound like this is the rule. This is the controversy that we have right now, that it may be more complicated than just an inflammatory condition. And so even diffusely, as I said before on the MRIs, even what seems to be normal appearing white matter can have some of this degeneration. You can see this axonal loss at small numbers of cells when there's absolutely no evidence of an infiltrative inflammatory reaction at that time. So the treatment approaches right now, I mean, degeneration first, well, immune modulator and anti-inflammatory therapy. That's what we're here talking about today as well, is the treatments for MS. And what we're talking about inherently is a reduction of the inflammatory nature of this disease, reducing the number of relapses and progression of disability. And certainly, you know, we have used techniques to completely ablate the immune system with the chemotherapies that are used for bone marrow transplantation or so on. And you can show that you've just pretty much shut down the inflammatory activity. Unfortunately, you will still see degeneration and more atrophy take place over time, even in patients where you have shut it down. And so we're looking at this now and trying to get a better idea as to what the interaction is between the degeneration that's seen in MS versus the original inflammatory activity. So my conclusion for this section is that it is an autoimmune disease. I mean, you certainly can see immune abnormalities that are going on here that are quite significant. But the primary event is actually not as clear as we might like to think. We have evidence that besides the autoimmunity, we are also getting neurodegeneration as well. As I'm going to mention in the next section, there are other environmental and genetic components to this that might lead to this occurring. So what we can see pathologically is an invasion of the central nervous system by T cells and B cells. That may be the initiating event, that in fact inflammation is first. But it also may be as a result of the degeneration that has already occurred within the brain and spinal cord, and it's an immune reaction to the antigens that are being released from dying back cells. We're not entirely sure on a patient-to-patient basis what the actual autoantigens are, what is being attacked. We can see that it's quite different from one patient to another, in fact. So it's not as if there's just one target in this autoimmune disease. But that's one of the goals, is to be able to personalize this and figure out what cells are in play and what the inflammatory nature is.